Hello everyone. Today we're covering chapter 10, which is about opioids, and this is the last chapter for the semester. Opioids are one of the oldest drug classes known, and it has been around for over 3,000 years, and it comes from the poppy seed plant. In the Middle Ages, opium combined with wine to make laudanum, meaning something to be praised, and not too long ago here in the United States, it was converted into morphine, which was isolated in 1806 and was used as a chemical formula and then became a prescribed drug. In the Civil War battlefield, a lot of morphine was used to treat soldiers, and soldiers, as a result, ended up becoming addicted to it. So, what are opioids? Well, opioids is any exogenous drug, meaning that the drug comes from outside of the body because your own body produces natural pain relieving neurotransmitters. But opioids are the ones that mimic those neurotransmitters. And so, it's any exogenous drug that binds to the opiate receptors, which produces analgesia, meaning pain relieving, and is blocked by an opiate antagonist. And so you have opioid receptors throughout your body. If you've ever hit yourself somewhere, like let's say you kicked something and then your toe hurts, or you hit your hand on the table and then it hurts really bad. But then you'll notice after like a minute, it starts to feel kind of good, and that's what people call the endorphin rush. Well, endorphins are the natural pain relievers that your body makes that bind to opiate receptors. And these drugs that we're calling opioids are the ones that mimic endorphins to cause that pain relief. And so it's any exogenous drug that binds to opiate receptors, produces pain relieving feeling, and so that's why it's used, therapeutically as well. And so the categories of opiate drugs, naturally occurring ones, are isolated from the poppy plant, and that's morphine, codeine, papaverine, and thebaine. And then it's been chemically modified to produce different types of compounds like heroin and fentanyl. And so parts of the body that you can find opiate receptors are in the brain stem, the spinal cord, and the intestines. That's why when you take pain relievers like Vicodin or Percocet, they warn you of, constipation, because it causes constipation just because there's a lot of opiate receptors in the intestine. So opioids are analgesics, meaning that they're pain relievers. And so pain is identified as any highly unpleasant sensory and emotional experience associated with actual or potential tissue damage. And pain has its purpose. It prevents you from further damaging your body, and it also activates for you to figure out how to treat that pain. And so it is used pharmaceutically to treat acute pain, which is short-acting pain, and it's useful. And it's also used to treat chronic pain, which lasts more than 3 months. It can be for like migraines, back pain, arthritis, neuropathic pain, AIDS, post-herpetic neuralgia, MS, and fibromyalgia, just to name a few diseases. Here in the United States, a lot of people have been treated for pain. In fact, 100 million people have at one point been treated in the United States for pain annually, and 12 million for chronic pain, meaning that they need this drug over time, 3 months or longer. And as a result, this has caused opioid overdoses and also addiction. And so in about 46% of people, death from heroin and synthetic opioids have resulted. And so the responses to opioid epidemic, the United States has taken action to try to reduce the addiction. And so by 1900, more than 4% of the U.S. population was addicted, and legislation followed. This is the Pure Food. This is the FDA. PFDA. Basically came up in the Harrison Narcotic Act. Basically came up with some laws to help reduce the opiate addiction. And so opioid endemic declared public health emergency, and changes in the opioid prescribing policies were implemented because back in the day, early 1900s, they used to prescribe these loosely, but now, they're considered Schedule 1 and Schedule 2 drugs, and so they have to be administered, through a doctor in very controlled portions. And so now there's guidelines for prescribing opioids and chronic pain. And this is a real thing. I actually used to work at a pharmacy long ago. And I remember my customers, at least the customers that were just the ones that would come to our pharmacy frequently, and the ones that were the most stressed, and probably the rudest ones too, we could tell they had an opiate addiction because, they were demanding their drug every time that they would come to the pharmacy, and it would cause all kinds of issues. And so I know it's a real thing just because it affects people emotionally. All right, so there are several definitions. So there's opium, opiate, opioid, and a narcotic. Opium is a mixture of alkaloids from the poppy plant, Papaver somniferum, and so this is how it looks like. And you can see here the different kinds of chemicals that come from it. They look practically the same, and so you have morphine, codeine, theanine. And an opiate is any naturally occurring opioid derived from opium. An opioid is any naturally occurring semisynthetic or synthetic compound that binds specifically to opioid receptors. Remember, those are the receptors that we have in our body, and share the properties of one or more of the naturally occurring endogenous opioids, endorphins, and encephalon. And so morphine and codeine and theanine, they mimic our own natural neurotransmitters, and our natural ones are endorphins and encephalon. So this is like endorphins and encephalon, which are natural chemicals that our own body makes. That's like our own body producing its own morphine. And these molecules here are mimicking the endorphins and encephalon. And if they mimic, that means that they can also act just like an endorphin or act just like an encephalon. So they bind to the opiate receptors and they activate them to cause pain relief. And that also indirectly activates dopamine. And so a lot of dopamine is released as well as the opiate receptors are being activated. And so those two play a role together. And so anytime you're messing with the dopamine system, that addiction is going to be involved. Narcotic is a Greek word meaning to numb or deaden, which is the effect of opiates. They're pain relievers. They help you feel numb and calm. So they denote an opioid, but also widely used to describe drugs or addiction, and hence includes non-opioid compounds. Opioids basically bind to opioid receptors in the brain to help relieve pain. Opioids compete with natural endorphins to produce pleasurable and calming feelings. And each drug has different strength, speed of action, and tolerance level. And so here you see normal activity with our natural endorphins, like in this bluish color. And the purplish color are the opioid drugs. And so here you have the opioid drugs and then the opioid receptors. So you end up having or producing more receptors as you have more drug. This is just like a feedback system. But if you notice, the opioid user is flooded with chemical that activates the opiate receptors. So basically, the types of opioid receptors are called mu, delta, and kappa. And so there's several types. And depending on what type of drug, each drug kind of binds onto one receptor more than another. And every receptor actually kind of has a different effect on the body, which we'll talk about in a few slides from now. And so opioid receptors are distributed, like I said, throughout the central nervous system with high concentrations in the cortex, periaqueductal, thalamus, and nuclei of the tractus solitarius, and also, of course, the ventral tegmental area, and in the spinal cord, as well as in the large intestine, and in the brainstem and the limbic system, which is why people feel euphoria. If it's in the substantia gelatinosa and thalamus, it gives that dull pain relief. If it's in the brainstem, then it's used as a cough suppression, respiratory depression, and pupil constriction. And the side effect basically is the constipation. Endorphins and enkephalins are the endogenous opioid ligands. And so basically, these are chemicals that your brain makes that it's like your body making its own morphine or its own codeine, so these are endorphins and enkephalins. In fact, drugs like morphine and codeine, heroin, all of that mimic endorphins. Okay, so opioid drugs act like endorphins. And so, why do we have our own natural endorphins and enkephalins? Again, it's just to relieve pain, and it's also an antidepressant, so it uplifts your mood. And so, endorphins bind to the mu opioid receptors and causes pain relief, enjoyment of natural rewards, learning and evaluation of future rewards, antidepressant effects, excess movement, decreased breathing, and constipation. So if it activates anything that has to do with reward, you know that addiction is obviously very possible. Well, it actually is the case, and so not possible, but people do become addicted to opioids because of that reward feeling. And also, opioid receptors tend to activate dopamine. Well, they don't activate, like, they release the inhibition of dopamine receptors, which means that dopamine receptors are constantly activated, and so you have these two working together. And your body also produces enkephalins, which are more like natural antidepressants. And so they are used for pain relief, enjoyment of rewards, and evaluation of future rewards, and also has this antidepressant effect. And these bind to the delta opioid receptors. And then you have another type of chemical called dynorphin, which binds to the kappa opioid receptor. And so it's an endogenous opioid. But yet this doesn't have that pain happiness relief. It's actually associated with negative emotions like unhappiness and hallucinations. So there's mu1 and mu2 receptors. So the chemicals that bind to mu1 receptors are more for analgesic effect. So it's that calming, pain relieving effect. Mu2 receptors are for analgesia, respiratory depression, euphoria, decreased GI motility, and physical dependence. This is what causes more addiction. And then you have the kappa receptors, which chemicals that bind to it tend to have an analgesic effect and also the dysphoria effect. So dysphoria is basically opposite of euphoria. So you feel great, and dysphoria, you don't feel so great. So the mechanism of action on opioid receptors are basically these opioid receptors, the mu ones, are found on the pre and postsynaptic cells. And what they do is something called hyperpolarization by letting calcium escape and potassium as well. And hyperpolarization means that it's much harder to activate those neurons, and so it doesn't excite them. It basically makes them calm. And so it decreases action potentials, which then lead to no pain. Exogenous opioid ligand. So when I say exogenous, this means that it comes from outside of the body. So now we're talking about drugs. Now we're talking about either synthetically made drugs or drugs that come from plants. So exogenous ones, and remember, these exogenous chemicals are the ones that mimic your naturally occurring ones. So they tend to mimic your endorphins and your enkephalins. And so exogenous opioid ligands are morphine, codeine, and you can find these in opium plants. Semi-synthetic, meaning that you kind of you still get them from plants, but you mess with it chemically as well. And so that's heroin, fulcodeine, ethylmorphine, Vicodin, OxyContin. And so Vicodin, OxyContin, Percocet, all of those, you can actually get them prescribed by a doctor. Those are pain relievers. And it's completely synthetic, which is completely lab made, is fentanyl, methadone, tramadol, dextropophene, sorry. I have a hard time pronouncing these, meropenem and Demerol. And so the ones that, cause the most pain relief are the ones that are agonists. And so agonist means that they mimic and they act like our natural endogenous chemicals. And so that's why morphine, methadone, oxycodone, hydrocodone, heroin, codeine, all of these, fentanyl have a really strong effect on our bodies. An antagonist means that it does the opposite, and so that's naltrexone and naloxone. And so these antagonists, these opposite affecting ones, are actually the drugs that are used to treat addiction. And then you have partial agonists, which is buprenorphine. So it doesn't have as much of a strong effect as the agonist. And then you have some that act like agonists and antagonists. All right, so let's talk about morphine real quick. So the history of morphine was first isolated between 1803 and 1805 by Frederick Sertiner, and tested the drug on himself, friends, and local people, and then originally named the substance morphine after the Greek god Morpheus, and it has a tendency to cause sleep. Merck began marketing it commercially in 1827, and morphine was more widely used after the invention of the hypodermic syringe in 1853 and 1855 by Alexander. Morphine is a pain reliever, and the route of administration can be orally through an IV, so it's intravenous, intramuscular, subcutaneous, which is like under the skin, rectally, epidurally, or intrathecally, which means the fluid in between like your spinal cord or your brain. If it's taken orally, the peak plasma drug concentrations are reached within 30 to 90 minutes. If it's intramuscular or subcutaneous, the peak plasma drug concentrations reach within 15 to 20 minutes, and so it's activated much faster. And of course, if it's intravenous, it's immediately. The bioavailability is about 25% of the drug, so even though you inject a lot, only about 25% of it gets used. It has a short half-life of approximately 2.5 hours, so that means that in 2.5 hours you don't feel the effect as much anymore. The distribution, basically morphine is distributed to skeletal muscle, kidneys, liver, intestinal tract, lungs, spleen, and brain, and so it passes through the blood-brain barrier. Morphine also crosses placental membranes and has been found in breast milk, and so it's dangerous for pregnant people to take morphine because the baby will basically be taking it in too. And so the metabolism and excretion of opioids. So let's talk about metabolism. Primary site of metabolism. Let's see if you can guess where. If you said liver, you are correct. It undergoes rapid breakdown, and it's broken down to the metabolites M3G and MG6. And the major metabolite morphine 3 glucocorionide has no pharmacological effect and is primarily excreted in urine. And so it's broken down to these two components. This component here just has no effect, so it's already excreted out right away. The minor metabolite morphine 6, as a potent morphine M6G, has a half-life of approximately 1 to 2 hours and is excreted in the urine. And so when it's broken down, and when morphine is broken down to morphine 6 glucocorionide, this is the more effective metabolite, but yet only lasts for a few hours and then eventually is excreted as well. All right, so let's talk about codeine. You can find this mixture of codeine and Tylenol together. Codeine sometimes is found in cough suppressants as well. And so codeine is not as potent as morphine because it has a lower affinity for opioid receptors, and so it's like a partial agonist, and so it's not as strong, although still has an effect. The route of administration is orally and intramuscular. It is commonly incorporated with NSAIDs and compounds employed in the treatment of mild to moderate pain. It's also used in antitussive, respiratory, and antidiarrheal preparations. And its oral bioavailability is 50%, so that means that when you take it, only 50% is used. And about 10% is metabolized to morphine, and the rest is metabolized to inactive metabolites. And so again, it just has a lower effect. It's a lighter effect than morphine. The effects in general are euphoria, but because it's not as strong as the other, more stronger drugs, it has a lower abuse potential. It's less sedative and less likely to cause respiratory depression than morphine. However, it may cause disorientation and excitement. Constipation is the most common side effect because, you have opiate receptors in your intestines. Then you have this other drug called purple drink, or scissor. People call it scissor, dirty Sprite, lean drink. And that's basically a prescription strength cough medicine mixed with Sprite and candy like Jolly Ranchers, which have this decongestant, which is the active ingredient is actually promethazine, and it causes like a sedative effect and can impair motor functioning. So promethazine depresses the central nervous system with codeine and depresses the respiratory system. So if taken together in larger doses, they can both stop the heart and lungs from operating. So if you take codeine and if you take promethazine together, that can be very detrimental just because it completely slows down and depresses the respiratory system. And so when it's mixed with alcohol and other drugs, the results can be even deadlier. And so this kind of drink, this purple drink, not recommended just because it completely slows down the central nervous system. And normally people mix things together. Some of the side effects include nausea, dizziness, impaired vision, memory loss, and hallucinations. But people, drink it or people take it just because of the calming, pain relieving effect. So I don't know if you've ever heard of the song Sippin' on Some Scissorp. So, it doesn't cause seizures, but it can increase seizure activity in those who are prone to them. So you have to be, very, very careful when taking any type of synthetic drug, which I do not recommend. All right, so now let's talk about heroin, which is a semi-synthetic opioid. It's also known as diamorphine, and it has up to 3 times the potency of morphine. It's made by combining morphine and acetic anhydride. Pure heroin is a white or brown powder and is typically cut with sugar, starch, or powdered milk. Black tar is a form of heroin that is sticky like tar or hard like coal. Its dark color is a result of crude processing methods that leave behind impurities. The route of administration frequently dissolved in water solution and injected. Additionally, it may be snorted or heated with the resulting vapor being smoked or inhaled. It is lipid soluble, so that means that it readily crosses the blood-brain barrier and is converted into morphine right away. Binds to the mu opioid receptors, basically hyperpolarizing them, causing them to have this calming effect. And it also, because it binds to the opioid receptors, it releases the inhibition on dopamine receptors, and so a lot of dopamine gets released as well. Heroin is heroin use involves a rush of pleasurable feelings as the drug mimics endorphins, producing a warm sense of well-being and increasing heart rate. Because remember, we said that endorphins, also affect mood and reward, and so you get that feeling, including the pain relieving. The rush of the drug is governed by the route of administration, so if you snort it, it takes about 10 to 15 minutes for the rush. It's less dangerous than injecting, but limits amount as the purity is unknown. And overdoses are less likely in this route, but still very possible. Smoking is the rush. You feel the rush like in 2 to 5 minutes. It's less dangerous than injecting since there are lower probability of overdosing. And of course, injecting is where you get the rush right away within 7 to 8 seconds. Higher probability of overdosing because your body just doesn't have time to clean it out to react. Disease may be spread if needles are shared. Involves heating heroin in water and most intense and quick onset of euphoria. It can also be injected intramuscular, which takes 5 to 8 minutes. High probability of overdosing as well. Disease spread through needle sharing, and so, but it's a slower onset of euphoria, and so it just takes a little bit longer, and it lasts a little bit longer in the body. Heroin can be a treatable addiction, although, difficult, but still treatable. So heroin users stop producing their own endorphins, and that's why they become addicted, because the brain just stops producing them. And so if your brain is not producing your own natural feel-good chemical, of course you're going to seek it. And so because your brain is not producing enough endorphins, you end up having withdrawal symptoms if you quit. And so the withdrawal symptoms usually peak between 48 to 72 hours after the dose, and they are completely gone within a week. And so it takes a whole week for your body to adjust. Sudden withdrawal for a heavy user may actually result in death. And so it's very important for a person, to go to a clinic and be supervised by a nurse, as they're withdrawing. Methadone and buprenorphine, which is an opioid antagonist, are two medications that have been proven useful in easing a heavy chronic user off of heroin without intense withdrawal symptoms. And so if these are opioid antagonists, that means that opioids, they can't bind onto the opiate receptors. And so here's a picture of it. So here is the drug buprenorphine. And so basically it blocks the opiate receptors. And so if it blocks it, that means that other compounds can't bind to it. And fentanyl is actually way stronger than heroin. It has a high affinity for mu receptors, meaning that it can bind onto the opiates. Remember, we said that there's different types of opiate receptors, but it likes the mu ones. And so it can bind onto it with ease, meaning that it activates it. It's approximately 100 times more potent than morphine. Very lipophilic, quick onset, seconds to minutes to activate, and it has a short half-life. Significant first-pass metabolism. So it'll go right through, so even if you ingest it, it'll go right through your intestines and still enter your bloodstream quite easily. The route of administration is by patch, buccal, tablet, nasal spray, and lozenge. The transdermal patch is preferred method for chronic pain management. And so this is can be prescribed, the fentanyl. And so patches slowly releasing fentanyl to the skin and the bloodstream over 48 to 72 hours, allowing for long-lasting pain management. Patches have also been used for many years in dogs and cats for post-operative analgesia. And this is how the patch looks like. This is a prescribed one. And some of the fentanyl side effects are depression, crying spells, suicidal thoughts, behavioral changes, anxiety and irritability, and hallucinations. So a treatment for opioid overdose, so if a person overdoses, you can temporarily reverse the respiratory distress by using this drug called naloxone. The mechanism of action is a competitive opioid antagonist, so it's just basically blocking the opioid receptors. And this is taken intranasally or intramuscularly. And so this is basically a treatment for opioid overdose. Okay. Now, different people will metabolize the drug differently because we all have genetic variations. It's the enzyme cytochrome P450, and I know you've heard about it in previous lectures, that are involved in some of the metabolism of opiates. And there's another enzyme which is highly polymorphic and also is involved in the breakdown. Patients fall into one of four metabolic categories. They can be extensive metabolizers, which is just normal function, so it's just regular average, metabolizing. They can be ultra rapid metabolizers, which is mostly of North African and Oceanic descent. So believe it or not, some racial groups are either more prone or less prone to the drug. And so in this case, the ultra rapid metabolizers, if they are breaking down the opiates rapidly, that means that the drug hardly works on them because of the rapid metabolism. Then you have intermediate metabolizers, which are mostly of Asian descent. So they end up having high plasma concentration of the drug. The drug sticks around too long and constantly is activated, so that means that they feel the effect of the drug a lot more longer. And then you have the poor metabolizers, meaning that they have a really hard time breaking down the drug. So if you have a hard time breaking down the drug, that means you have a high plasma concentration of the drug. And the drug sticks around for too long, and it's chronically activating your receptors. And so in this case, if you notice, there's the opioid overdose death rates are highest among whites and males. Now, that relates to the previous slide in which we saw that Europeans have a poor metabolizing ability. And so here are some statistics if you're just curious. So white and non-Hispanic tend to be more addicted to opioids. Black and non-Hispanic 10.3%, and while white is 17.5%. Hispanic has an even lower addiction, and it could be because we're fast metabolizers, and males tend to be more addicted than females. So here are some more videos for you to watch. There's quite a bit of interesting videos out there. If you want to learn more about it, feel free to take a look at these extra resources that I have provided for you. And this concludes the end of our lecture.